Today's webinar will center around empower yourself, learn about hypertension, heart attacks, strokes, chronic kidney disease, and congestive heart failure. I may spend a bit more time today on congestive heart failure, and that kind of like all routes, when you have cardiovascular heart disease, leads unfortunately to, guess what, congestive heart failure. So it's going to be imperative to listen to what I have to say here. Dr. Rudy Moyse, my other colleague, he is on the other end as well. He is he's our go-to guy, basically. Dr. Moyse is located in North Miami. He's a part of the CHP team as a vice president. And Dr. Moyse will do a lot of the conversions, if you will, interpretation, if you will, to translation to that of Creole. And we're extremely happy to have Dr. Moyse on the Zoom this morning. So having said all that, we want to get started. So let's see if I can bring things up here correctly here. So let me share the screen first. And if I can undo this thing now. It should be fairly flawless today. We'll see how that works out. I'm going to share. And I'm going to get rid of that one. And I'll be sharing this.
Good morning, Dr. Reynolds, and good morning, everybody.
Good morning, Dr. Moyse. Can everyone see the screen?
Yes, sir. We got you, Doc.
Okay, great.
Yes.
So Dr. Moyse has joined us. I'm glad that Dr. Moyse is here because I'm going to pitch it back and forth between myself and Dr. Rudy Moyse. I love what I'm seeing here with one of the churches that I go to from time to time for sure, who is our leader, our spiritual leader in this, which is, shall we say, moderator, Pastor Toby Philpott. And I'm looking at his church here, which is kind of cool to see that. And so good to have that on. Anyways, that's me, kind of like, I call it my avatar, basically. And it's just, again, this is brief stuff about me. It's not about me, it's about us and about what we're doing. I did graduate from Michigan State University College of Human Medicine back in 1978. Don't try to date me, guys. Okay, I started medical school when I was like 6 years old. Okay, I was like a Dookie Howser, you know what I mean? But in any event, became board certified in emergency medicine in 1985, so some 38 years ago. And I've been licensed, of course, in 13 states. Remain actively licensed in 13 states, including Florida, Ohio, Arizona, California, Georgia, Texas, Michigan, New York, North Carolina, Louisiana, North Dakota, Virginia, and Nevada. I'm also the founder and CEO, along with my wife, Christine, of Centers for Health Promotion for more than 25 years of service. All right. So again, the whole purpose for what we're doing is to bring chronic disease and prevention to our communities, typically of color. And when I say of color, I mean the whole rainbow of colors. So we had to, of course, put in, the logo here, which is very important because it's through their getting us this grant, which is, if you guys are nerds and if you guys want to look this up, it's Florida Statute 381.7351 through 0.7356. And if you Google those numbers, then you'll be able to see that. Now, this is being recorded, so you guys always play this back at your leisure. I've always liked the idea of recording things because it gives me a chance to go back and things that I may have missed, which is oftentimes, then I'll miss that. So if you want to write, you can, but understand again, you'll be able to go back and play this over again. I want to suggest to you all that perhaps you hold off on your questions until at least the end of each segment, because a lot of people will want to have questions answered, and we're more than happy to do that. We have a lot of experts on, so we're going to be able to do that. So again, this is a chronic disease prevention and wellness. This, of course, is evidence-based. Why is evidence-based important? Because you want to make sure that you're getting the facts. Typically, there's only one set of truths. The environment that we live in today, it seems like they have alternative facts. Well, we're scientists, and we believe in evidence-based and data-driven. And Dr. Gavin, he's certainly one of the experts in that regards as well. All right. So again, it's going to hypertension, heart attacks, strokes. And there's my colleague, Dr. Rudy Moise. He looks a little bit more dapper on this one as he does looking at it now, but he looks still pretty doggone good. And Dr. Moise and I, we've been extremely close friends for, well, it's a little bit more than 36, 37 years. So we've known each other for quite a while. And he's still my friend. How about that? Dr. Cadilla, she will not be on with us today. She is our board certified chronic disease specialist who happens to also be a doctor of pharmacy. And we like to go out in these communities, and you'll see a few of us here. I don't know if you see my pointer or not, but of course that's yours truly. And then it's Dr. Moise. Dr. Moise is very demonstrative. Okay, he puts his whole heart and his soul into it. So as he's giving these different talks and so on and so forth, then he can really get involved. Here's some other doctors that we have involved with this as well. So we have a team of right about, I want to say maybe at this point about 42 people that are employed by CHP. CHP really works well because we have a partnership. And when I say partnership, I do mean a partnership in every sense of the word with our community health, our community faith-based excuse me. And it's extremely important for us to keep that connection because it's through that partnership that we're able to do some special things that other organizations have proved that they cannot do. So when you talk about the faith-based community, you're talking about CHP. Talking about CHP, talking about the faith-based community. So we're all together as one in this. So hypertension. Now, I always look at, it's the silent killer, first of all. It is the number one killer of people of color, i.e. African Americans for sure. And when we get that blood pressure of 120/80, we'll talk about that too. That's just, I call that sometimes a myth, right? It's a myth because if your normal blood pressure runs typically, let's say 100 and 106 over, let's say 72, you come into the emergency department seeing someone like me, and your blood pressure is 120/80, your pressure's up a little bit, right? So we always want to make sure that people know, and that our constituents and our people that we educate know that you should know your numbers, right? And there's different ways to know your numbers, and your blood pressure is one number. Then you look at your PSA as another number. Follow me. There's a heart score. That's a number for that too. There's a diabetic score. It's a number for that also. So I want you guys to begin to know your numbers. That way, when you guys meet with your doctors, then you'll be able to meet with them with some intelligence. And I'm a firm believer that the patient is the captain of their own ship. Okay, the physicians, we're supposed to be stewards, the one to help you all get better through the good Lord's help. I always tell my doctors when I'm teaching emergency medicine that, listen, we're here to do the small things. God still does the big things. It's called miracles and stuff, right? So we don't have the right to tell a patient that you have X number of months, X number of years to live, because we don't know that. And I always ask the patient, well, what did Jesus say? He usually hasn't spoken to him yet. Okay, move on. Okay, dietary controls is very, very important. And especially when we talk about hypertension, we talk about salt. Salt is a mortal enemy. It's the enemy of congestive heart failure. When we start talking about congestive heart failure, we're talking about this thing called a BNP. That stands, I used to call it beta natriuretic protein. It is really beta, but it's actually beta brain natriuretic peptide, right? So we'll talk about that in a little bit because that tells you a lot when you start talking about congestive heart failure and to put you into certain categories. There's typically 4 categories. We say A, B, C, and D, and we'll talk about that later on. Other thing is when you are treated for blood pressure issues, and I always say this to my brothers, especially African-American males and other Hispanic males too, we have a tendency to stop taking medications because for some reason or another, some of these medications will make John Henry, I'm trying to keep this politically correct and not sure who all's on this year's webinar, but it means that your libido, right? Some of these medications affect your libido. So guess what happens? We stop taking the medications. When you do that, guess what happens? Now your blood pressure is a silent killer, can lead to different things such as strokes, heart attacks, kidney failure, a lot of congestive heart failure, a lot of different bad things. So you want to make sure if you're on medication, for your blood pressure, To me, once you have hypertension, you have it. The vast majority of hypertension, that's what's called essential hypertension, which means that there is no known etiology. There's no known cause for it. We just happen to have it. I think a lot of that is environmental stressors, and also what we eat. And again, if untreated, you get to these different issues. So you want to stop eating your salt. That, like I said before, that is a main issue, especially with people of color, African Americans, Hispanics. We tend to like our food spicy, but also, unfortunately, a little on the salty side. Salt is a killer. I know there's studies out there because I read some of these studies where it says salt does not really matter. Well, apparently they did not study Black folk and other people of color, because salt is a major problem within our community. So we want to make sure that you get nothing else out of this here particular webinar. It's going to be cut your salt out completely if you can. Let's put it this way: try not to add any salt to your food. Now, if you cook with a lot of salt, you need to decrease what you put in your food, because you're going to be eating that. All right. Exercise. My son Justin gave a really nice presentation last week. He'll be giving another webinar as well on physical activity, exercise, and so on and so forth. And we're saying that you should exercise probably about 30 to 40 minutes, 3 to 4 times a week. What does that mean? It does not mean going out, as some people that I heard earlier this morning say, they were out there walking for 5 miles. Okay, 5 miles, because he wanted to make up for not walking, I guess, the day before. So he's going to walk an additional 2.5 more miles, right? Well, doing that, you put your heart at risk, and so you want to make sure that before you start doing any moderate exercises, that you really consult with your physician, whether it's your primary care doctor, whether it's your internist. Talk with a healthcare professional. It may be a PA, physician assistant, but talk with someone first. Remember this also is that CHP are what we call patient advocates. Every one of us as physicians at CHP, from myself, Dr. Gavin, Dr. Rudy Moyce, and others, we're here to make sure that if you have any concerns, you can call a number. It's 888-539-4111. I'm available 24/7. And that's whether you have a problem with your doctor about these kind of issues, or if you have just other concerns that you may have. Because patient advocates got to be available to you. Unfortunately, a lot of your doctors are not necessarily patient advocates. They're about, unfortunately, they're about having to make money to keep the doors open, keep bills paid, right? So they end up pushing through volume, and therefore patients really don't have the opportunity to express what their concerns are. So it's kind of important. Develop a good weight plan and stick to it. Now, the stick-to-itness part of it can be kind of tricky, I guess, at times. But I started my weight plan 2.5 years ago. Okay. And I can't show you what I used to look like, because I used to be big. I got up to like 265 pounds. I'm only 5'10". And I'm not ashamed to say it, with the help of Manjaro, which is a trapezoid, as well as cutting my carbs, which to me was very important, and exercise. Today I weighed in at 202 pounds, right? And I feel good. I think I look pretty good. Wife has not made any complaints about how I look. And I think I'm doing pretty good. And, when you start looking pretty good, you start sending out photos to all your friends. So I'm sure Dr. Gavin got a few photos. I know Dr. Moyce has, and certainly know that Pat Philpott has. And the wife sees these big, humongous posters of me in the house. Pastor Philpott, he's been at the house along with Dr. Gavin. And I said, dang, what is Dwight doing with these big photos, pictures of himself? Because I got to tell you guys, when you start feeling good, when you start feeling it, you start looking good, doesn't mean you have to drop, a large number of pounds, right? But you just want to feel good for yourself. So you want to do it not just for others. You want to first of all do it for yourself, because self comes first. Perseverance comes first. Stop smoking. Cigarette smoking especially. It definitely has a direct link to not just cardiovascular disease, but also lung disease and bladder cancer as well. I'm sure we probably all know someone that either died from lung cancer. I know my uncle did many years ago, but we all know someone, right? And the easiest thing to do is to talk about it, but it's hard for those that we're trying to convince to stop smoking cigarettes. Now I mentioned, I mentioned cigarettes really hard. There's a few of us on this Zoom that have that occasional cigar. So we try to cut back as much cigars as we can because we do the oral cancer, and there's some other cancers too that are involved with cigar smoking as well, as well as pipe smoking. Again, like I said before, take your medication as you are directed to do. You got to be compliant, right? There's nothing worse than a non-compliant patient. All of us doctors have it, tell you what you should do, and sometimes you don't do it. It's like a very basic thing, right? It's like you go into the doctor's office, you have, let's say, urinary tract infection. The doctor tells you, I'm gonna put you on, let's say something like Septra DS, double strength, 1 tablet twice a day for 10 days. All of a sudden, the urinary tract infection starts feeling better. In fact, you don't have any urinary complaints. So guess what you do? After about 4 or 5 days, you stop the medication. Then there's a recurrence of it, and it becomes more and more difficult to treat. So be sure to follow your doctor's instruction. And if you guys if you guys want to just follow up and check up on your doc, Google it. WebMD is okay. A patient comes to see me, I don't care if they, whatever they scour in terms of the internet or whatever, bring it to me too. Maybe I can learn something. We're always constantly learning as docs. This is just, and I'm just going to be very brief with this slide. These are things that typically we talk about eating, but the fact of the matter is that we're ethnic people, right? We like to eat certain things, certain foods, but it's how you prepare it. So in a nutritional setting, then we'll be talking about those different things. I can tell you though, that obviously dark leafy greens are very good. Veggies are good for the most part. Beets are excellent for you. Bananas are good. Don't overdo bananas. If a doctor say, well, I'm putting you on this thiazide diuretic, that could be hydrochlorothiazide, hydrochlorothalidone, ACTZ. I'm sure you guys may have heard of that. And they say, but you need to eat a few bananas a day because we want to keep your potassium up, because you will most likely lose some of your potassium, which is a very important element to have in your body. However, in order to raise, it's like this, typically you have anywhere between 3.5 to about maybe 4.5 to 4.6 maybe milliequivalents, small amount of potassium that's necessary to be in your body. In order to raise your potassium 1 milliequivalent, you have to eat almost 10 bananas a day. You're going to be big as I don't know what, okay? So the bottom line is that know the foods that are rich in potassium. And a lot of us, people of color, we tend to like, guess what? Watermelon, loaded with potassium, right? You got apricots, you got all other kind of fruits and veggies that are high in potassium, but would not make you get a lot of carbs in. And of course, pears, plums, so on and so forth is also good for you as well. Moving right along. So the different medications, we talked about this the last time I gave the talk, ACE inhibitors. I'm not a big fan of ACE inhibitors for people of color, although Dr. Gavin, he can certainly chime in on this. Lisinopril, which is one of the major ones that we tend to receive, at least our patients get, it can cause what we call, and it's a very, very important thing, by the way, guys. This is something that will make your tongue swell. You'll have this anaphylactic type of reaction to it. And you can be on lisinopril for a number of years before you finally, boom, it hits. And when it hits, it truly becomes an emergency. I recall seeing a patient through the year once that came in, and she was put into the waiting room, and to find out that she was really having a bad reaction to lisinopril. The nurses thought, well, it can't be that because, hey, listen, she's been on it for like 6 years, no problem. By the time she got back to me, when I was talking, she couldn't hardly breathe, so I intubated her right away. And I got to tell you guys, we had to put in people know about the size of an ET tube, endotracheal tube, had to put in like a 5, kind of like a pediatric tube, basically, because it was narrowing down on us very, very quickly. So I'm not a big fan of lisinoprils. The BBCs, I'm skip down here to the calcium channel blockers, those are pretty doggone good. Amlodipine, it's a first-line drug. Oftentimes we do combine it typically with one of the thiazide type diuretics, whether it's chlorthalidone or whether it's ACTZ, hydrochlorothiazide. The ARBs are also pretty good too. These are angiotensin II receptor blockers, or sartan rather, and it's used sometimes in patients that have congestive heart failure issues. So it's a pretty good medication. And we're going with that. Beta blockers, atenolol. I gotta tell you guys something. I feel so embarrassed to tell you guys this, but I've been on, it's called Teneritic. Teneritic is a combination of atenolol, a beta blocker, and hydrochlorothalidone, right? I've been on this thing for 30 years. My blood pressure has been marvelous. We're at about 100, 118, maybe over 76, 78 or so. It works for me, but guess what? Beta blockers are kind of like passe. Most doctors are no longer prescribing a beta blocker for blood pressure issues. But for me, it works well. I'm sticking with it. Your main one, let's say that you're diagnosed through one of our clinics, because we do give health fairs, right? Let's say that I find that we have a diabetic, we have a hypertensive person that's out there, not blood pressure like maybe 200 or whatever it is, because those patients need to get to the ER. We need to diffuse them fairly rapidly. But let's say that your pressure's up, maybe 140, 150 over, let's say 110. The best medication to start a patient on for Black folk, people of color, is going to be what? A thiazide diuretic. And then that's just a fact. So number one treatment for hypertension can be used alone or in combination with a calcium channel blocker, such as amlodipine, is our African Americans. That's just that's what the literature shows, and I'm sure it's fairly accurate, and it's all scientifically based. Consequences of not taking your medication. When we were coming up as kids, our parents said that for everything you do, there's a consequence to it. Well, here's a consequence also. It hasn't changed. So if you don't take your medication, heart attacks are real. Strokes are very real. And if you know anyone that's had a stroke, maybe you've had a light stroke. They call it sometimes a TIA, which is a transient ischemic attack. They call it a mini stroke. That lets you know what's going to be coming down the pike unless you straighten your situation out. Congestive heart failure. We'll be talking about that quite a bit. That's the number. If you have a BNP, that is a brain natriuretic peptide greater than 400 to 1,800, it's called kilograms, PG, per ml, that means that you're in acute heart failure. So these are numbers that we need to know for sure. But if you have a history of congestive heart failure, that's a number that you should know as well. Problem is that with BNPs, it can also be up in people that are on dialysis because it's a fluid type thing. And chronic kidney disease. So you go through different stages of that. I won't go into any details about it, but I'll say this to you. GFR, which means glomerular filtration rate, that is the rate in which the blood goes through your kidneys, right? And to clear it, we're talking about if your GFR is greater than 90, it's normal. For African Americans, if it's greater than 70, 65 to 70, it's also very normal. If it's 60 to 89, you have what we call a stage 2 kidney disease person. If you're 30 to 59, you're stage 3, and so on and so forth. The worst one you'll come to obviously is if your GFR, which means you're not making very much urine typically, is less than 15 or so. That means you're either on dialysis and you're hoping for a kidney transplant because that's end-stage renal disease. Blood vessel stuff, I won't talk about that much, but these are what we call aneurysm. These are blood vessels that happen to balloon out. When they rupture, depends on where it's rupturing at, it can become a major problem. So let me show you guys a little video here. Hopefully this will work pretty well today. Can y'all see that still?
It amazes me that it's 2024 and people are still wearing
some of these
earbuds. So you can get rid of these and get rid of these because what?
Can y'all see this? Can everybody see this or not?
Yep, we got you, Doc.
Good, thanks.
Yes, we can.
Sir, are you okay? Are you okay? Can I help you at all?
Okay.
You're clutching your chest. Is another part of your body hurting? Anything else hurting?
Having trouble breathing and my arms a bit sore.
All right, you know what? I'm going to call for some help, but let me get you into a more comfortable position. Come on over here. Let's get you down on the ground. I think you'd be more comfortable this way.
Watch what she does.
Great. All right. And I'm going to call 911. You stay right here. Help's on the way. They should be here really soon. I'm going to stay here with you.
So what she's doing, obviously, right, she's identified the problem. The next step, which is a major important step, is call 911. Don't be a hero yet. You may have to become a hero, but not at that moment.
There we go.
Now, when you tell a patient to, be calm and take it easy, hey, I'm an ER doc. These people are kind of like, they're panicky because they know that they're having something that's going on that's not good.
Mark is experiencing a heart attack. Calling 911, encouraging him to get into a semi-seated position, and reassuring him are the right things to do. If Mark was a family member or friend, offering one adult dose of uncoated aspirin would also be recommended if he was safe to take aspirin. Now let's go inside the body to see what is actually happening. The heart is responsible for pumping blood throughout the body via blood vessels, also known as the circulatory.
Let me stop for a moment and say something here too, guys, about the aspirin. The American Heart Association, along with the American Stroke Association, came out with a very important update. I want to say maybe 12, 13, 14 years ago now. That aspirin, yes, for heart attack patients, we want to give that, right? But if you never had a heart attack, you never had a stroke, the recommendation that you do not take 81 milligram baby aspirin. What they found is that the science has shown that more people suffer from having GI bleeds than from protecting them from having heart attacks and or strokes. Please remember that. So if your doctor have you guys on aspirin, 81 milligrams is baby aspirin, you never had a stroke or heart attack, ask the doctor, why are you on that? He or she should be up to date with that information. It's been over 13 years ago now.
Or cardiovascular system. The blood carries life-giving oxygen and nutrients that are needed by every cell and tissue in the body. Keeping our arteries healthy, clean, flexible, and free of plaque is key to ensuring cardiovascular health. The heart is a muscle, and just like every other organ and tissue in the body, requires blood and oxygen to stay alive. The heart receives its own supply of blood from a network of arteries called the coronary arteries. A heart attack occurs when there is a blockage in one of the coronary arteries. Without blood and oxygen to that part of the heart, the tissue begins to die. If left untreated, permanent tissue damage or death will occur. A blockage can occur for a few reasons. Young, healthy arteries are flexible and elastic, but over time, the walls of our arteries can harden and become blocked. Atherosclerosis is the buildup of fatty tissues called plaque, which can narrow our arteries and restrict blood flow. A heart attack occurs if there is a blockage in one of the coronary arteries. Blockages can also occur for other reasons. Sometimes the plaque can break away from the wall of the artery and disrupt blood flow. Plaque can also break off, causing a blood clot to float freely. If the clot blocks blood flow through a coronary artery, it causes a heart attack. If a clot reaches the brain, it can cause a stroke. As a first aider, your job is not to diagnose. You will not be able to determine if in fact it is a heart attack, as naturally we cannot see inside the body. But your job is to recognize the signs and symptoms of a heart attack and act fast. Getting someone to the right hospital for the right care can make the difference between life and death.
Okay, so let's stop at that one thing in a minute. Another great one to follow that. And this is about AEDs. And I'm sure everyone is familiar with an AED, but some of us don't necessarily know how to use an AED. Let me see if I can bring that up. So far I'm done. I want to say fair, I guess. Let's just get back to our slide now. This is very important, guys, because you need to know how to use these things. The AEDs are found in churches and airports and grocery stores, doctor's offices, of course, but they're found all over the place, right? But if you see it, you don't know how to use it, it doesn't do anything. So let's see if we can play this. Can everybody still see the screen?
You know, a lot of investors right now are sitting on the sidelines, thinking they're doing quite well, earning for. Today we're going to review some safety tips when using an automatic external defibrillator. Now, AED technology has shot through the roof over the last decade. You can't go out in public without finding an AED hanging on the wall. You're going to find them in shopping malls, airports, I found one in a bathroom stall the other day. So AEDs are out there, and we want to use them because they're our best chance for saving an adult during a cardiac arrest. But we have to remember what these devices really do, which is stop your heart. That's right, they stop your heart. So they demand a little respect. So let's review the safe operation of an AED. First,
Very important, guys, very important.
be familiar with your equipment. If you have an AED, know how to use it. Review the owner's manual and be familiar with that device. Next, implanted devices. Most implanted pacemakers or pacemaker defibrillators will be implanted under the patient's left clavicle. That's why when you apply the pads, you'll put them on the patient's high right, low left. That's two.
Remember this, guys, high right and low left. It'll tell you, the pads will actually show that thing to you also, but you have to know where to put it. High right, right up the chest wall, low left. It's in the lateral part of the actual chest wall itself. For ladies that have pendulous or very large breasts, you must elevate the breast and put it right on that side there. I'm sure you'll explain it.
To avoid placing a pad on top of or over an implanted device like a pacemaker or implanted defibrillator. Next, medication patches. Do not place an AED pad on top of a medication patch. Make sure you remove the medication patch first and dry off the area. Many of these medication patches have a metal layer built into them to help keep the medicine going in one direction inside the patient. So again, do not place an AED pad on top of a medication patch. Now, should the patient have, say, a birth control patch on her hiney, we don't have to go looking for that. We're only concerned about the medication patch placement wherever we're going to put our AED pads. Next, gaseous environments, explosive environments. When can this happen? Well, it can happen in a workplace if you're using flammable gases. If that's the case, you may want to refrain from defibrillating the patient in that atmosphere until it can either be vented or preferably the patient moved out of that environment. The last thing we want is this. Clear, shocking in 3, 2, 1. That, of course, would be that. Now, generally, electricity and water don't mix. And the same holds true when we're applying and using an AED. So we want to make sure that the patient's chest is dry before we place the pad. This is for a couple of reasons. One, so that water coming off the patient doesn't transfer the shock to another person. And two, we want that energy going through the heart, from one pad to the other pad and through the heart. If the energy gets diverted elsewhere because the patient's wet, that's less energy that could have gone through the heart. Now, in most AEDs, they'll have an accessory bag, and in that bag should be some kind of towel so you can dry the patient's chest off before applying the AED pads. Make sure your patient's dry. Now,
Yeah, guys, because typically, guys, patients having a heart attack, they're diaphoretic, right? Which means that they're sweating. It's usually a cold sweat. And there's nothing worse than putting an AED pad on, and it's just going to slide a little bit. It's not going to give you that real good solid contact. Contact for this is very important.
when applying the AED pads, you're going to have to expose the patients into.
Another quick thing. Yeah, Doc has to explain this stuff. When you see us giving the chest compressions, we say about inch and a half. Fact of the matter is that you're going to probably bust ribs. You'll probably separate the sternum from the chest wall itself. But that's okay, because the bottom line is that you got to get adequate compression to move the blood out of the heart to the rest of the body. So we'll tell you in a book, it's 1 1/4 to 1.5 inches of compression for adults.
That bag with your AED. And this is for cutting through sweaters, t-shirts, and underwire bras or brasiers. Now, in large-breasted gals, when she's lying flat on her back, her breasts are going to move laterally. You're going to place one pad, high right, and then the low left. Do not place it on top of the breast tissue. Lift the breast up, and you're going to have to place it underneath the breast. Again, lower left, the patient's axillary on their side. Not only do we have to have the heart in between the pads, but we have to have the pads as close to the heart as possible. If I were to put a pad on top of breast tissue, that's just further the energy has to go to get to the heart. So again, on large-breasted gals, high right, lift the breast out of the way, go underneath the breast. Now, remember when putting the pads on the patient,
He said something that's kind of strange to hear a healthcare professional saying for gals. We don't have gals, we have ladies. So maybe I should send him maybe a little note. I'm not sure when this was made. I'm going to find out, but there's no such thing as gals. These are ladies.
wires coming off of those pads. Make certain that the wire doesn't accidentally get caught underneath the pad. Again, anything that diverts energy away from going through that heart is a bad thing. So again, make sure that the wires don't get stuck underneath the pads when you're applying them to the patient. So you're looking at this picture and you're thinking, hey, it's Bigfoot. No, it's actually my father walking to the bathroom at a rest stop in Schenectady, Wisconsin during a family camping trip. They took the picture, it got posted as Bigfoot. The point I'm making here is look how hairy he is. My dad's not covered with hair, he's covered with fur. When applying the AED pads, the pads have to make good contact with the skin. They have to be able to read the rhythm and interpret it, and have to be able to deliver the shock. If I put pads on a furry guy, the pads won't make contact. Now, in your accessory kit, hopefully you have a razor or something that you can get rid of some of this hair. If not, a technique you can use is push the pads on as hard as you can, rip them off, give the brother a quick Brazilian, then put the pads back on. Now, this technique might require the use of a second set of pads. One pad to remove the hair, a second set to interpret and defibrillate the patient. One of the most important safety concerns when using an AED is remembering to clear the patient before you hit that shock button.
That's a critical point, guys, because I've seen people that get knocked down. Because understand this current that's being delivered is 360 watt seconds. It's a lot of energy. That's why the patient will actually jump when they hit it, right? Well, you don't want to be jumping also. And in fact, remember what the guy said earlier, this jolt, this sheer shock is meant to stop the heart, come back up on a normal rhythm. So we go from B-fib to sinus rhythm, hopefully. And if you're in the vicinity, and if you get hit with that electricity, you'll have the same thing happen to you too.
Before you hit that shock button, you look from the head to the toe of the patient, make sure no one's touching the patient. I'm clear, you're clear, shocking in 3, 2, 1, administer the shock. So quick review, remember to watch out for wetness, big boobs, hairy people, implanted device.
Again, big boobs. I don't like that terminology, but big breasts, whatever. I'll deal with that later.
Medication patches, and remember to clear the patient.
Okay, that's that one. So let's move from there to this next slide.
So in this video, I'll be showing you the
Hold on,
essential
turn that
plain
down.
tie you must have in your
Let
wardrobe.
me go back.
I love plain navy ties. I've got
Me love doing navy ties. I don't love doing navy ties. Let's see. Let's go back. Okay. Can you see me again or not? You should be able to see me now. We're good?
Yeah, we see you. Yeah.
Okay. So let's move to the next slide over here would be. Okay. So now we move to the next subject here, basically. This is heart attacks, right? Now, I'm going to share with you, and I'll probably skip to him fairly quick because it maybe more time I want to spend on it. We do have time, by the way, but this is Mr. George Beasley. He is a security person, owns a large company. And George had attended one of our seminars, one of our events, and he'll tell you about his experience. So hopefully it'll play. Let's see what goes on. So far, we're doing pretty good. Okay, this is Dr. Reynolds, Center for Health Promotion. And the gentleman that's sitting in front of us, he felt that he would be having his funeral, if not today, tomorrow, I guess it is. And Mr. Beasley is the owner of a very large security company, just got a couple of major contracts, by the way, multi-million-dollar contracts. But he happened to be someone that attended one of our seminars with chronic disease prevention. I believe it was over either Shiloh or it was over at Antioch Missionary Baptist Church in January, I believe it was. So he took heed to some things that I was talking about, and that was that when it came down to heart attacks, I told him that time is muscle, and we got into that. We explained exactly what I meant by that. Basically, I said to him, and said to them, a whole bunch of people there, I guess well over 400 some odd people there, and George happened to be one of them. And I explained that what I mean by that is if you have chest discomfort, pain is something that's subjective. So I say chest discomfort, maybe a little short of breath, maybe a little nauseated, you may be sweating. Well, knowing why you're sweating, you may feel a little lightheaded. Those symptoms to me, you need to have someone else check it out. And it's heart attack to proven otherwise. So I told them that time for the heart is muscle. the longer you take to have this checked out, the more muscle mass you lose, and your chance of surviving a heart attack is not very good. So I'll let George tell you about his story. And George, you can go ahead and begin. Appreciate you doing this.
Hello, my name is George Beasley. This back for about 2 years ago. I started having small shortness at the breast and coughing and stuff like that, but only lasted maybe about 2 or 3 minutes. Sometimes 30 seconds.
Now, notice what George just said. And it's very common for especially Black males to look at these things as being very simple, having mild shortness of breath, a little bit of chest discomfort. Didn't really talk about pain or anything, right? Because we're kind of like the macho group of guys, right? So just listen to George talk. He'll get serious here in a minute, for sure.
I get myself in the chair, they go away. Just recently, it's come on, maybe going in about 5 minutes or so. And a couple of weeks in the office, I told one of the secretary there, I said, I don't have to go to the doctor, something wrong. I'm having chest pains and I'm breathing and having difficulty in breathing. Yeah. So just the week on Saturday,
okay, now you just said the magic word. Now you're going to have chest pain, shortness of breath. Getting a bit more interesting.
I attended one of the seminars, I think was in Boynton Beach. And Dr. Reynolds was talking about heart attacks, strokes, and stuff like that, and time with muscles. And
when you say time is muscle,
yeah,
got it.
Time is muscle, right?
Yeah, right.
And then I started paying a little more attention to my symptoms than I was before. Thank God that I did attend that seminar there. And Saturday, it started with me again.
Saturday being how many days ago was that from today's date?
Maybe about 6 days ago.
6 days ago, okay.
Last Saturday. Okay. And I was on my way home and coming off 9 to 5. And I started getting chest pains and coughing. And my jaw started tightening up and stuff, and both arms started tightening up. And so instead of making a left going to my house, I made a right. And the hospital right there in front of me, about 2 minutes away from the hospital. I drove in to the emergency room. So I was thinking about what Doc Reynolds.
1 second here. George and I just drive in. George has a Tesla. He told his Tesla to get me to the ER ambulance side.
Said time with muscle. So I drove into the emergency entry there, same entry that the ambulance go in. It was at that point. I drove in there and got security guard said, "You can't park here." I just gave her my keys and I went in. And the nurse saw me and she just brought out the wheelchair, wheeled me in. And that was Saturday afternoon. So I started coming around sometime Sunday. And so far, everything went real great.
So let me ask you a few questions then. When you came to the emergency department, which is pretty much protocol for us, doctor, protocol for us is we get you ready for what we call going to the stent lab. Right. So put a stent in, perhaps. Cardiologists, everybody, this is like an activation of a system that all hospitals have that take care of heart patients. Right. So I'm sure they activated that system, sure they got you prepped and get you ready to go. You had an EKG done that showed what we call a STEMI, that's an elevated segment. Right. ST segment MI, which is a real emergency actually. And that's why you end up getting, how many stents you have put in?
I had 3.
3 stents put in?
Yeah. 2 of my, well, actually one of my arteries was about 90% closed, one was 80%. 2 was 80%. So they went in through the wrist and did procedures and everything. And believe it or not, a couple of days after, I'm lying up in the hospital, just relaxing. I look down at my feet turning regular brown like it used to, but before it was black. I started getting a lot of oxygen, felt good, felt real good. Today I feel real great. But
you look awesome, man. You look awesome.
I was telling Doc, man, about Saturday I've been having no feeling. It was a very close call. Something I really should have paid attention to 2.5 years ago.
Right.
Before this whole episode took place.
Well, listen, George, I really appreciate you, being willing to come on camera because a lot of people end up seeing this But they need to understand the seriousness of purpose, that you adhere to a message that you heard. If nothing else, you recall time is muscle.
Yeah.
And for people that have a potential stroke, I tell them time is brain. As long as you keep that in your mind, and I'm sure you pass this on to other people now, you become like what we call an unofficial ambassador, CHP ambassador, to get goodwill about what we're doing regarding cardiac health and that kind of thing. So I really appreciate you doing this.
And also, Dr. Key thing is educating people. People have to be educated. You know, you walk around, you think nothing gonna happen, especially black men. I have 6 boys, and I'm always on their back. I got one son, he won't go to the doctor, he won't do nothing. But my other boy, they do. They get in and go to the doctor, get yourself checked out and everything. But thank God for Dr. Reynolds. Also, he's been a friend of mine for quite some time too.
Yep. So we'll stop there and let me move on. See if I can do this right. Get back to the presentation. Can everyone still see the screen? I can't believe it. I'm doing pretty decent. All right. So that was about George said. Now, congestive heart failure. Congestive heart failure is something that is near and dear to me because I've had an uncle die from congestive heart failure. A couple of my cousins died prematurely from congestive heart failure. And it doesn't have to be that way, right? But you're going to hear the main problem here with congestive heart failure. Typically, it's going to be salt. But there's all kind of things, structural problems, valvular type problems. Hypertension plays a major cause, certainly in people of color, black folk especially. There's all kind of different things that can cause you to have congestive heart failure. I'm just going to let's see this briefly. In fact, hang on, maybe I just go past that. Let me just go past it for a minute. One of the major symptoms of congestive heart failure is shortness of breath, especially when laying down. Like, let's say when you stand, when you're sitting up, before to lay down, you got to sit up again because you get short of breath. That is called orthopnea. Orthopnea means that you cannot lay down flat because there's so much fluid that's in your lungs. When you sit down flat, it just seems like it's filling up even more. So that's kind of important. Weakness is a sign of congestive heart failure, primarily because, understand again, the heart is a pump, right? So if the heart is not pumping the blood throughout your body, that means that you're not getting the energy, you're not getting the oxygen, and you're not getting the nutrients that your blood will take to your muscles, etc. Speaking of that, it means that there's also a decrease in blood going to the heart. Remember, the heart is pumping blood out, but the heart also has arteries on it too. 3 major arteries: the right coronary artery, left coronary artery, and the left anterior descending coronary artery, and the circumflex. So it has arteries that it has to get. When the heart is in diastole, then that's when the blood fills up the blood vessels, the coronary arteries. And that's not happening again. Guess what you have? You have chest pain, irregular heartbeats. All ties in, right? Because if the heart's not able to pump efficiently, it's going to start doing some extra interesting beats. Swelling of your feet, your legs, your hands. That's very, very common in congestive heart failure. I've seen patients come to the ED. They have these large legs. You press on their legs, and boy, the thumb goes in almost 2 inches. We call it pitting edema. That's a real bad. That's a bad sign also. Anxiety. Why would they have anxiety? Heck, if you can't breathe, you could be anxious. I don't know what, right? So you usually come in almost fighting you because they can't breathe. We have to get these people where they can breathe. Very doggone important with that. And of course, being tired. Tiredness is that's key also. That's an important thing. How do we make a diagnosis of congestive heart failure? We do what is called a resting and an exercise EKG or electrocardiogram, ECG, which is what it really is. Echocardiogram is extremely important because it's going to tell us about the thickness of the heart walls as well as the operation of your different valves. Valves are very important, especially the aortic valve and the mitral valve. Very, very important. One is to get blood out of the heart. The other is to bring blood on the opposite side, which is the mitral valve on the left side of the heart. CT scan, MRI scans, PET scans. These are studies that can also be done. But remember, I mentioned to you guys earlier about brain natriuretic peptide, BNP. If you're over 5,000, you're looking at death within a matter of three months or so. That's just what the numbers show. 53% of those people will die within 3 months. 2 years, 69% of those same people will have died. 5 years, 100% of these people are gone. So if you're diagnosed with congestive heart failure and you're given these numbers are real numbers. They mean something, right? And like I said before, BNP can be up when you have chronic kidney disease because you retain fluid, and that's your natriuretic peptide part of it. Treatment, number one treatment that we can control: low sodium diet, low salt, and you take your blood pressure medications. Miracle drug, FACEP is out there for diabetes, is out there for certain congestive heart failure, and it works pretty well. And maybe if Doctor wants to chime in on this, Dr. Gavin wants to chime in on this, then it's fine. Dr. Gavin, you want to chime in on this point about FACEP and about the congestive heart failure and the diabetes?
Yeah, I'd be happy to, Dr. Reynolds. This is really important. And let me just back up a second, because I think one of the things that's really important when it comes to heart failure, clearly the earlier you make the diagnosis and the earlier you start treatment, the more likely you're going to be to halt the progression, because you can go through stages. You start with a risk, and then you go through stages. That starts at stage A, and then you go through stage B, C, and D, and each one is progressively worse. And you want to get in on this early to start making sure that these treatments can really have the effects that they are capable of. If you have other conditions, like diabetes or high blood pressure, things that Dr. Reynolds has alluded to, then the likelihood is high that you might develop congestive heart failure and you won't know it. Okay, and so one of the things that you have to be careful about is when you can't do the usual things that you've always done in your activities of daily life, walking up a step. I had a patient who couldn't carry a load of mulch from his truck to his garage like he used to without shortness of breath. That was the first clue. He had diabetes. That was the first clue that something else was going on. That's when you need to start asking and looking. And that's also when you have to start looking at some of these other treatments, for example, like FACEP. Not just FACEP. FACEP is a member of a class of drugs called the SGLT2 inhibitors. I talked about that a little bit when I talked about diabetes. FACEP, Jardiance, Invokana, all of them have now been shown to have really powerful effects on treating heart failure, whether or not you have diabetes. So they're diabetes drugs, but they have these important extra benefits of helping to improve heart failure and helping to protect your kidneys. And that's why it really is important, especially for high-risk groups like African Americans, to take advantage of earlier diagnosis, definitive diagnosis, and then early treatment, and then using these new drugs that can have benefits beyond what they are traditionally known for. It's nice to have a drug that lowers your blood sugar, but if you can lower your blood sugar and protect your heart and protect your kidneys, that's the one you want.
Exactly. Thank you, Doctor. Dr. Moise, since you are a strong practitioner and have a large number of patients that you're responsible for, can you give me any some feedback regarding your experience with patients that have congestive heart failure?
Well, let me say a few words about the reinforce what you said earlier. And I've been practicing general family practice now for the past 35 years, and in North Miami and Orlando. And most of my patients, they're from the Caribbean community, they're Haitian. And sometimes with this patient, you have to understand the culture in which I do. So I'm able to communicate with them and make them understand. When Dr. Reynolds said earlier, you have to know your numbers. This is so crucial because if you know what your normal blood pressure is, if you know what your hemoglobin A1C is, if you know what your PSA is, for example, when you follow up with the doctor and then it's higher or lower, so at least you know if you have done the right thing, follow the doctor's instruction, or if you have not. So it's very, very important that you know these numbers. Dr. Reynolds mentioned about smoking, cigarette and cigars. Cigarette smoking, as you said, no smoking, indeed. because when you smoke, this will affect your lungs and also give you cancer. For cigar smoking, that as you mentioned, most people when they smoke cigars, they don't really inhale it deeply. They just puff it out and so on. But you mentioned that it may cause you. Some people may end up having some oral cancer, something like this, or something. You know? So things that which is worse, cigarette smoking or cigar? You may maybe discuss this a little bit later. One thing about my populations, sometimes you really have to explain to them basics information. For example, if you tell the patient to take the medication 3 times a day, do you know what I've seen? The patient take 3 medications at the same time.
Yep.
So you have to say, well, take medication in the morning, at noon, and the afternoon. Like that, they understand. Because they think 3 times a day means that they can take it, everything at the same time. One other comment that Dr. Reynolds said is that some blood pressure medication, some men don't take them because they decrease the libido. Indeed, men in general, particularly from the Caribbean, from Haitian, I mean, they love the libido. So if the medication does not interfere with the libido and they cannot perform, they're going to stop taking it. That's why it's very important that you're comfortable with your doctor. Say, doc, whatever it is, I don't understand. There's something happening. Since I started this medication, I cannot perform. So the doctor will understand and go ahead and change the medication for you. There are all the medication available, but you have to feel comfortable with your doctor to explain to him that something is not working, so he can adjust it for you. I've had high blood pressure now for over 20 years, and I never knew that I had it. When I went for physical in the military, the pressure was elevated. And I thought, wait a minute, I never had any symptoms. That's why Dr. Reynolds said silent killer. Sometimes you never know that you have it, but some most common symptoms of high blood pressure for people who may not know is headache and dizziness. You feel uncomfortable, and sometimes you have a little bit of shortness of breath as well. But classic is headache and dizziness. When this happens, you have to take your blood pressure because most of the time it is indeed elevated. And then in terms of the treatment, man, it is so easy to treat if you remember to take your medication every single day. Some people they forget because they have to take their kids to school, they have to go to work, but you have to find a way that every morning or whenever the doctor asks you to take the medication, that you take it. In terms of diet and exercise, this is my secret sauce. I tell you, I work out. Dr. Reynolds recommended like 30 minutes, like 3 times a week. I do hour and a half, 4 times a week. In fact, I train with his son, Justin, who spoke last week. And if you have seen my beautiful abs, I'm pretty sure some of you were on the.
I don't hear about your abs. I'm jealous.
So yeah, and I tell you, that's because I just turned 70 last Sunday, and most people say, Dr. Maurice, you look 70, you look like a 48 or 50, 55. Again, that's because I know what it is for me. I follow my diet. I avoid eating too much starch, fried food. And again, my Haitian brothers and sisters, they love the griot and fried pork. They love the rice and beans. They love their tostones, bon Thursday, what they call it, and those are very high in carbs, very high in fat, and that's a problem. We're not telling you do not eat nothing at all, but at least moderate portion. You cannot eat like a whole bowl of rice and beans every single day. You cannot and fried food, the tostones, they're delicious. I mean, I love them too. But instead of taking 3 or 4, take maybe half of one. Sweets. We love sweets. And personally, I cannot drink my coffee without putting a little sugar in it. But don't go ahead and put like 3 or 4 little bag of sugar in it because that's too sweet. And sugar it affects a lot of things in your body as well. So I'm sorry, I talk a lot, Dr. Reynolds. I just wanted to kind of reemphasize some of the things I have seen in my practice for the past 30 years. So I'll give it back to you.
Yeah, I know. Thanks, Rudy. Great job. I don't know if Dr. Rowdy is on now, but I know that he was on earlier. And Dr. Rowdy, he is a practicing ER physician. So if you're on, Dr. Roddy, you can go ahead and you can chime in anytime you want to chime in. I want to tell everybody that we have just broke our record in terms of registrants. We have 142 registrants that's been a part of the Zoom or that will be receiving the Zoom as a recording. So thank you guys for really showing up. And this is something that we can't really talk enough about. Let me segue into something else before we go.
Dr. Reynolds,
Yeah, sure.
before you move on, can I just comment on one thing that Dr.
Please.
Moyes raised that turns out to be so important? You know, sometimes we're really worried about how often people are keeping to the schedule of their prescribed medications. And we are in the habit of asking them, well, how many times are you taking your medicine? Are you taking your medicines as prescribed? One of the things that I've really found that can be helpful in addition to asking that question is to ask them, how many times do you find yourself missing your doses? Because that's really what you want to sensitize people to. So it's just another helpful thing that you can add to the mix to make sure that you don't fall into some of those traps that Dr. Moyes just raised in terms of people staying on schedule with these medications. No medication, no matter how good it can be, is going to do you any good if you're not taking it as prescribed.
Great. Yeah, I want to mention something also, guys, that we may be in a position to work with a major company that deals with diabetes and hypertension, different devices and medications, and it's called it's more of a how can we say it's a clinical trials, different things, right? And you're probably like me. Whenever I hear about clinical trials, I think, well, am I going to be a guinea pig? No. This is the deal, guys. In order for us to get involved at the highest level of care, healthcare, with the newest technology available to us as a people, with medications and technology, it's going to be critically important that we're going to be engaged, of course, our faith-based partners, which will be a major part of this particular venture, if we go into it, along with Dr. Gavin and others, and our clinicians. And imagine this for the first time ever. We're going to be the center if you all want to be participating in it. And I ask you guys to make a comment about that. Put it in your comment part, put it in the chat, and Pastor Philpott, he'll certainly pass it on to me as such. But this is an idea that is great, I think, for the community. And that, guess what? These major companies manufacture medications and let's say devices. They're not doing anything in the Black communities and Hispanic communities, because guess what? Apparently we're not showing, I guess, maybe the interest, or could it be also that we're just getting the opportunity to do that, right? So we want to break that mold, but understand again, you're with trusted advisors, trusted healthcare professionals, and of course, your trusted ministers within your different communities. This program cannot be successful unless we have communication, and everything has to run through, to me, in my opinion, through the various churches of faith that we're dealing with. This could be a beautiful thing, guys, because we're talking about bringing the cutting edge medications. Yeah, the medications out there now that you're taking, they're pretty good, but my God, if they got something better that they're developing, we want to be a part of that. If they have new technology, information that we can put on our bodies, we want to be a part of that. So I'm just throwing that out there now, guys, because I know that we did have a conversation with a company called Abbott, and it went pretty well. But I want to make sure that we just throw it out there. I want to begin to get that out in the ether now, that we want to get people engaged in at least the conversation of doing the things that we can do as a very solid coalition of the clergy and medical personnel and the scientists, and make sure again that we're protecting our people. I would not want to have anyone involved in anything that I would not want to be a part of. And I'm sure Dr. Gavin and Pastor Philpott and certainly Dr. Moyes and others feel the exact same way. But these are opportunities that are out there, and we'll see where it goes. But moving on, and we're really, guys, we're moving at a pretty good pace. Believe it or not, we really are. I just want to go ahead and play this here little video. It's from the Mayo Clinic. It's about stroke. Stroke is something that if you ever saw someone that had a stroke, it kind of depends, right? If they had a hemorrhagic stroke, which fortunately it's rare, It's about 50% of all strokes are hemorrhagic strokes, which means that a blood vessel breaks in your brain, pops or ruptures, and you bleed. We just try to get your blood pressure down to kind of like maintain that. On rare occasions, they're able to go into your skull, into your brain, and maybe put a clamp on what may be known as a very aneurysm or something that may be leaking. But whenever something ruptures in your brain, such as a blood vessel, it's going to be an artery. Then that means it's going to be like a jet propulsion, a pressure. As the blood is putting pressure on your brain, it pushes it down to what we call the uncus. The uncus is the very base of your skull where the opening is. And for those of you who may remember from back in high school, I guess biology, it's called the medulla oblongata. Okay, the medulla oblongata. That's where the brainstem is, and that's where all the different functions are there. Control function of heart rate, respiratory rate, temperature, all these things are there. So when that goes down, pushed down through the uncus, then you what we call cone. That means that your pupils are dilated, fixed, right? Fortunately, the other stroke, and that's what we call when we talk about time is brain, is what we call embolic or ischemic strokes. And those strokes count for roughly 85% of all strokes are ischemic. Those are the strokes that we give you TPA. Sometimes we can do it either through an IV. We can take you up to it's called IR, the interventional radiologist, turn the catheter up, go right into that particular part of the brain, and either do an embolectomy, which means that they pull out the embolus, or they can put the TPA right into the actual clot itself. And I got to tell you guys, I've seen people that came to the ED, could not talk at all, totally aphasic. They could not move anything, and they were looking straight ahead. I'm saying, hey, that person, they ain't gonna make it. Find out they had what is called a middle meningeal artery. I'm sorry, a middle cerebral artery thrombosis. Okay, and that's a major blood vessel. And imagine now they have a little bit longer time, by the way, which I never knew that until you read more, I guess. They have almost up to like 4 or 5 hours. And some people have been successful in pulling that out in a day. But for the most part, we want to get you from the moment you have symptoms. That means the moment that you have symptoms, not when you start having, really things going really bad. Let's say you start symptoms at 11 o'clock at night. You can't tell the wife, and the wife can't tell the husband, well, you know what? Let me wait until the morning. Wait until the morning, that's going to be too late. You cannot get what we call these clot busters waiting that long. So let me see if I can get started with this. It'll be brief. It comes to you from Mayo Clinic.
I was told by my urologist to throw away all my blue pills and do this one simple blood flow. I'm Dr. Robert Brown,
Are you seeing that?
neurologist at Mayo Clinic. In this
You're not seeing
video,
that?
we'll cover the of a stroke. What is it? Who it happens to?
Oh no, we're not seeing it.
Diagnosis and treatment. Whether you're looking for answers for yourself or someone you love, we are here to give you the best information available.
Share.
You've likely heard the term stroke before. They affect about 800,000 people in the United States each year. Strokes happen in 2 ways.
Let me go off the share
In the
and try
first, a blocked artery can cut off blood to an area of the brain, and this is known as an ischemic stroke.
You see it now.
85% of strokes are of this type.
Yes.
Yes.
This type of stroke.
Very important concept.
I'm Dr. Robert Brown, neurologist at Mayo Clinic. In this video, we'll cover the basics of a stroke. What is it? Who it happens to? The symptoms, diagnosis, and treatment.
This is only 5
Whether
minutes.
you're looking for answers for yourself or someone you love, we are here to give you the best information available. You've likely heard the term stroke before. They affect about 800,000 people in the United States each year. Strokes happen in 2 ways. In the first, a blocked artery can cut off blood to an area of the brain, and this is known as an ischemic stroke. 85% of strokes are of this type. The second type of stroke happens when a blood vessel can leak or burst, so the blood spills into the brain tissue or surrounding the brain, and this is called a hemorrhagic stroke. Prompt treatment can reduce brain damage and the likelihood of death or disability. So if you or someone you know is experiencing a stroke, you should call 911 and seek emergency medical care right away. Anyone can have a stroke, but some things put you at higher risk and some things can lower your risk. If you're 55 and older, if you're African American, if you're a man, or if you have a family history of strokes or heart attacks, your chances of having a stroke are higher. Being overweight, physically inactive, drinking alcohol heavily, recreational drug use, those who smoke, have high blood pressure or high cholesterol, have poorly controlled diabetes, suffer from obstructive sleep apnea, or have certain forms of heart disease are at greater risk as well. Look for these signs and symptoms if you think you or someone you know is having a stroke. Sudden trouble speaking and understanding what others are saying. Paralysis or numbness of the face, arm, or leg on one side of the body. Problems seeing in one or both eyes. Trouble walking, and a loss of balance. Now, many strokes are not associated with headache, but a sudden and severe headache can sometimes occur with some types of stroke. If you notice any of these, even if they come and go or disappear completely, seek emergency medical attention or call 911. Don't wait to see if symptoms stop, for every minute counts. Once you get to the hospital, your emergency team will review your symptoms and complete a physical exam. They will use several tests to help them figure out what type of stroke you're having and determine the best treatment for the stroke. This could include a CT scan or MRI scan, which are pictures of the brain and arteries, a carotid ultrasound, which is a sound wave test of the carotid arteries, which provide blood flow to the front parts of the brain, and blood tests. Once your doctors can determine if you're having an ischemic or hemorrhagic stroke, they'll be able to figure out the best treatment. If you're suffering an ischemic stroke, it's important to restore blood flow to your brain as quickly as possible, providing the oxygen and other nutrients your brain cells need to survive. To do this, doctors may use an intravenous clot buster medicine, dissolving the clot that is obstructing the blood flow, or they may perform an emergency endovascular procedure. Now, this involves advancing a tiny plastic tube called a catheter up into the brain arteries, allowing the blockage in the artery to be removed directly. Unlike ischemic strokes, the goal for treating a hemorrhagic stroke is to control the bleeding and reduce pressure in the brain. Doctors may use emergency medicines to lower the blood pressure, prevent blood vessel spasms, encourage clotting, and prevent seizures. Or, if the bleeding is severe, surgery may be performed to remove the blood that is in the brain. Every stroke is different, and so every person's road to recovery is different. Management of a stroke often involves a care team with several specialties. This may include a neurologist and a physical medicine and rehabilitation physician, among others. Now, in the end, our goal is to help you recover as much function as possible so that you can live independently. A stroke is a life-changing event that can affect you emotionally as much as it can physically. You may feel helpless, frustrated, or depressed. So look for help and support from friends and family. Accept that recovery will take hard work and, most of all, time. Strive for a new normal and remember to celebrate your progress. If you'd like to learn even more about strokes, watch our other related videos or visit mayoclinic.org. We wish you all the best.
Are you getting caught short in the rain? With the bearskin waterproof soft shell jacket, you won't even need an umbrella. This is the ultimate.
Get out of that one. Give me one moment, guys. We're almost finishing here. So we should be back on the screen. They can see you, right? So you just saw that. And again, when you start talking about strokes here, we start talking about balance. And I was talking last week with my son, Justin, about balance, things that we need to watch out for. this is a side of stroke, guys, but as we get a little older, we tend to be a bit more, I wouldn't say clumsy, but I guess we really do a little bit. We forget that things are kind of like obstacles for us. A throw rug may be in the wrong place. And at night you're walking around, you have to go to the restroom, whatever you got to do. And you stumble and you fall. That's a real setup for a hip fracture. Seen too many of those through the ED. There's certain things, exercise-wise, that Justice spoke about last week. He'll be back on, I think, in about 3 weeks, to talk about some more of these different issues. Headaches, dizziness, these are all signs of potential strokes. When a person comes to the ED and tells us, I had the worst headache I've ever had, that is a subarachnoid hemorrhage until proven otherwise. Worst headache I've ever had, doc. I never had a headache like this before. You got to do something about that fairly quickly. Vision, it could be peripheral visual loss. It could be complete visual loss. Typically, it's going to be in one eye or the other, or it could be in both. It could be in both. The face, the dragging face. I don't know if you see my face or not. I'm trying to drag a little bit and slurring my speech a little bit, because that's how it would most likely be, right? That's what strokes look like, basically. Remember this also, whatever side the facial problem is, the stroke is on the opposite side, okay? So if you have a left-sided facial drop, then you have a right-sided paralysis or weakness of the right arm, the right leg, etc., right? So that means that the bleed is on what side? The right side. So it's just going to be the opposite, because there's a crossover thing there. So we look for arm weakness, look at that right away. Speech, again, you may have difficulty just getting the word out, enunciating, right? You may stutter or stammer. I do that from time to time, but you notice today I'm a bit more controlled because I want to impress everyone that I'm talking with, right? But what happens is that we have to slow our speech down so that our brain and our speech can be in sync. Other thing, like I said before, time is brain. Is that 911 thing? Yeah. But if you can't get 911, again, if you got signs of a stroke, just started, forget about 911. Just get to the hospital, let you have the spouse, whomever you're living with, get you to the hospital. That's just about the stroke. Now, we're pretty much finishing up now, but I want to put this out there, guys, because you guys need to know what else we do. We have coming up on October the 11th, our inaugural, our first of the series of health fairs. It's given in collaboration with, in partnership with the Antioch Missionary Baptist Church, of course, the Florida East Coast Baptist Association, and Comprehensive Medical Health Center. Again, this will be on October the 11th. And can you tell me what time that is, anyone? Christine? Pastor Philpott?
I am not sure, Doc. Ms.
Hold
Ray.
on, Doc. I will tell you what time.
I think it's probably 11 o'clock.
It's right there, 10 a.m. to 3 p.m.
10 to 3?
Yes.
Okay. And the other thing too, guys, is that what we're doing there is going to be a little different. Yes, we will have an area where we're going to be doing the educational part of things, right? But also we will be doing blood pressure checks. And if your blood pressure is high, if you don't have a doc, then I'll most likely start you on one of those thiazide diuretics, most likely clothalidone. We're doing A1Cs. A1Cs is a very effective way of screening people for potential, shall we say, diabetes, either, shall we say, pre-diabetics or diabetes itself. If your A1C is high, I always like to get like a second test just to make sure that we don't have a false positive or even a false negative. So, but our job when you get these studies done is for us to follow up with you to go over those things. If you have a positive study, whether it's A1C or blood pressure issue, then you will be referred to a local physician if you don't have one that's in your area, or it's called also a qualified community health center. The other thing, guys, is that we have CHWs, community health workers, that CHP has employed, that are there to be a linkage between the things that you don't have. For instance, we have people that don't have food to eat. That's a real deal here. So we want to make sure that we get them to social services to make sure they get food stamps, whatever that they need to have to assist them with that particular need. There may be a need for transportation. How can you get to the doctor's office if you don't have anything that's going to get you there, right? So the CHWs, community health workers, they're assigned to make that linkage happen. And they're going to be walking you through the course to make sure that you are going to get these services. Then it comes back to me or to one of our team members to make sure that it was proper follow-up for you to get those different services. Other thing, we ask about this in the ED all the time, emergency department all the time. Oftentimes, when people are being abused at home, especially women, they tend not to talk about it because they're afraid to talk about it. Well, guess what we do in ED? And everyone else is doing it now. I'm pretty sure that the primary care docs are doing it. Rita, I think you guys are probably doing it too. You want to ask about if they're safe at home, okay? If a male comes with the spouse or the significant others to the emergency department, we want it to be a private conversation between the doctor and the patient. So we can legitimize that. We can make sure they understand, the male knows that, sorry, we have to step out for a moment. This is just a doctor-patient relationship here, and it's how it rolls here. And I say, yeah, I use the word just how it rolls here because you have to talk the way people talk to us, right? And you'd be amazed in terms of the women that are in distress, but they were afraid to talk up in front of their husbands and or significant other. And we're talking about 95% of the people that are abused this way are women. Yes, there's roughly about 5% or less that are males. I have not met one yet, but the literature says that there's roughly 5% of the men that are getting their butts whipped by these ladies or their significant others, right? So, but I want to let you guys know that these are linkages and they're to link these things up. Baby don't have shoes or whatever it is, then our CHWs, community health workers, are there to make sure that we bridge a link there to make sure that you get the services that you need. A job. Some of you guys may be looking for jobs. There's ways that we can connect you with that also, right? And I love what's being said now about you don't have to have a college education, even high school education, to get into certain programs to be able to make a living wage, right? So just keep in mind, guys, that these things are available, and it's going to be through a lot of these community health fairs that we will be giving. We're also going to be doing some extra things on social media, as well as, here in our webinars. It's not necessarily scheduled to be in our webinar. It's something that we have to do as a deliverable, but I'm going to do it because I know that we should be doing it. For instance, we look at things like prostate cancer and men, especially Black males. Not only is the incidence high, but the incidence of males dying of prostate cancer is also high because we're not getting the care that we need to have, right? And there's a stigma associated with that as well. Well, you have to get your sons taken out, all of a sudden you can't do whatever. Well, there's ways to get around that, but we need to make sure that we identify these men. For the general population of people of color, whether you're going to be African-American, Hispanic, Asian, or others, but especially African-Americans, we have a higher death rate from colon cancer because we tend to pick it up fairly late. So we'll be doing a discussion on prostate cancer, colon cancer, and of course, breast cancer will always come to the fore as well. So we want to let you guys know that we're going to be working outside of our scope of what they expect us to do for our deliverables, because we want to make sure that we let people know that we really care about our communities. Because our grant doesn't cover that, doesn't mean that we can't get on a Saturday, like we're doing now, for about an hour or so, to talk about things that really affect our communities. So if you guys have any ideas, subject matters that you guys want to talk about outside of cardiovascular things that we've talked about before, outside of diabetes, then just make sure that you I guess you chime in on the chat. Let Pastor Philpott know, and then we'll begin to look at how we can incorporate that into another one of our webinars. All right. So does anyone have any questions? We can start with questions now. We got a half an hour.
Dr. Reynolds, could I just, before the questions come, just
Sure.
Add to something that you talked about just a little bit ago, and that is to revisit the whole issue of clinical trials and clinical research, because this is something that we're going to be talking about from time to time going forward. And it's really important for our communities to understand that first, the FDA, the Food and Drug Administration, requires that before any drug, before any device can be approved for use in the treatment of people with any condition, it has to be shown to be safe and effective in that population. And this is one of the reasons why groups like ours will talk about clinical research trials and so forth, because the only way we can do clinical trials to show that something is safe and effective in our communities is that we have to participate. Okay, and I would just simply ask the question. You know, many drugs have been tested and they're on the market, but the truth is that they've only been tested fairly sparsely in communities of color. Now, when I ask you the question, what would you have more faith in? A drug that you are being prescribed that has been tested in 300 people that look like you and your family, or a drug that has been tested in people, in 3,000 people who look like you and your family? Well, I think it's an easy answer. The more proof we have that it works effectively and safely in people who look like us and our loved ones, the more confidence we can have. The only people who have some control over that is us. So when we talk about clinical trials, let's forget for the moment about the old days of Tuskegee and so forth. Trust me, the people who run the institutes at the national research level, for example, the folks at the National Heart, Lung, and Blood Institute at the NIH, the National Institutes of Health, the person who runs that is a former mentee of mine. The person who runs the National Institute of Diabetes, Digestive, and Kidney Diseases at the National Institutes of Health is one of my former students. So we know who's in charge nowadays. So we can come to you with confidence that these studies are going to be designed well and they're going to be on the up and up completely. And we need to participate so that we will know that the data that comes out of them applies to us and our loved ones in ways that can be meaningful and beneficial. So we'll get into that more and more, but I really wanted to emphasize that point, that when you hear us talk about clinical trials in the future, it's really critically important for us to be major participants in those in our communities.